Yes, ACCORD was a clinical trial which was organized by an NHLBI almost more than a decade ago. And the main purpose was to find out whether some intensive treatments like intensive glycemic control, blood pressure and lipid control would be beneficial in preventing CVD in people with diabetes. The trial was completed almost 10 years ago, but now we have the data, we have samples that we can use to try to answer other questions. And the one we are particularly interested in is whether we can use genetics to personalize those treatment, finding out whether there are some subgroup of people defined genetically that can respond in a more positive ways than other people. So we have found some genetic markers which can be useful to personalize two interventions. One is intensive glycemic control. We have two markers which can be used together as a genetic risk score, and the people with a very low genetic risk score are actually can benefit from intensive glycemic control, where people with a high genetic risk score instead can have a detrimental response, in fact, a paradoxical detrimental response to intensive glycemic control, in the sense that they have increased cardiovascular death instead of a reduction of cardiovascular events. This is one. The second one is about fenofibrate. Fenofibrate is a drug that was designed to reduce triglycerides and increase HDL cholesterol. And the clinical trial have been having mixed results. Some very small effects, some trials had that, some trials couldn't show that. But then we found a marker in the target for this drug, PPR alpha. And these genetic markers can define some people who really derive a benefit from this intervention as compared to people for which this intervention is not effective. So actually three markers, two for intensive glycemic control, one for fenofibrate, that can be used to optimize and personalize this treatment in people with type 2 diabetes. Well, I think that there are two goals at this point. One is to validate these markers. This was done, these results were obtained in a trial that was not designed for this purpose. So I think that it would be useful to have studies now that are designed specifically to try to find out whether these markers can be used in the way that we found out in ACCORD. The second one is that we should aim to find the mechanisms, the molecular mechanisms through which these genetic markers act. And in this way we may be able to find other targets for new intervention and new drugs. Well, since ACCORD was completed, there have been new drugs that have been shown to be effective in preventing cardiovascular disease in people with diabetes. And for instance, SGLT2 inhibitors, GLP-1 agonists. So I would guess that we should try to see whether also for these drugs we can find markers, genetic markers, that can identify people who are more likely to derive benefit than to derive harm or derive no effect from these drugs. So there is a lot that we can do because there are new interventions that we can leverage. The challenges are somehow, first, to understand what are the criteria that must be met for these approaches, these personalized approaches, to be brought to the clinical practice. And we don't have really a clear idea of how strong of an evidence we need to implement that in everyday care. And the other one is that somehow there was a lot of enthusiasm at the beginning for genetics. At the beginning, I mean 15 years ago. And then that enthusiasm waned as people realized that the genetic effects were very subtle, very small. But now that we have, in fact, found the genetic effects by putting together different markers, we have substantial genetic effects. We have to try to revamp that interest in the community, both in professional society, but also in practitioners, so that they can actually start using those genetic markers.